Good afternoon and welcome to AHCC Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and HOPE assessment data collection issues that matter most in home health and hospice. AHCC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for AHCC, and I am happy to be hosting this afternoon's session. And now I'd like to introduce our guest for this episode. And I apologize, I am having a advancing my slides. So I'm going to and see if it works for us. Oh, apologies for the technical difficulties beginning of this. We do have AHCC Advisory Board Lisa Selman-Holman with us today, and we are going to be talking about the first experience and what we have learned. Let's see if that advances the slide. All right. And before we get the discussion, listeners, if you have any questions for Lisa today, please go ahead and ask them in the chat pane, and we'll try to get to as many of those as we can. And Lisa, I'm going to turn things over to you. Just let me know when to advance to the next slide.
All right, thanks, Jan. I'm having a little internet connection problem as well, so if you cannot hear me all of a sudden, that's part it, but we'll record it and provide it later if we can't get it done right now. But well, let's get started. All right, so the HOPE was effective October 1st, 2025. And so we had the HIS before, the Hospice Information Set, and that wasn't really so much of a problem once we got started. And then we are sort of transitioning to the HOPE. Well, the HIS only contained 47 total standardized items, and it was just admission and discharge. And then all of a sudden we have the HOPE, which if you look at the all item set contains between 196 and 200 items, depending on how you count them. And not only do we have admission and discharge, but we have this HEV1 and this HEV2, hospice update visit, and this non-time point, the SFV, the symptom follow-up visit. So that's not its own time point, but it's its own visit. So that was very confusing in the beginning. Next slide. So we had this whole structural shift. Organizations underestimated how disruptive HOPE would be. I know that we had a lot of education prior to October 1st for folks to learn about HOPE and how to complete HOPE. And we essentially didn't have a lot of people reporting in because I don't think anybody really thought it was going to be a big problem, or perhaps they thought it wasn't really going to happen, because that kind of happens sometimes with CMS, that they propose something and then it doesn't happen, but it did happen. So now we have longitudinal encounter-based reporting. We have required RN in-person visits at defined time points, and we introduced those condition-triggered requirements, that SFV, symptom follow-up visit. Early failures really were not about learning the tool, so they were kind of right. They didn't need a lot of education. They needed it once or twice maybe to get it done, but workflow misalignment between compliance and daily operations was really the hurdle we had to get over. Next slide. So for example, this is just an example between compliance and daily operations. You have to have an HEV1, a hospice update visit, must occur between days 6 and 15 after admission to hospice. That person must be an RN, it must be an in-person visit, it must include those reassessment items that we see from HOPE, and if the visit doesn't happen in the window, even if it was clinically brilliant, you captured everything, the patient was getting worse, you did wonderful things for this patient, if that visit doesn't happen in the window, it doesn't count. In other words, you have to be on time with the HEV1 or it doesn't count in your whole quality compliance. So then we have the daily operations reality. We have an existing workflow on days 6 through 15. Of course, this is just an example. So maybe the case manager RN visits weekly on a fixed day. The LPNs or the aides cover the intervening days when the patient needs some service. Staffing and routing are optimized for productivity and geography. Schedulers aim to avoid extra visits unless there's a real crisis. So operational thinking, you may say this patient looks stable, so the RN doesn't have to visit until next week. But if next week is outside that, day 15, then you've messed up. Next slide. So visiting and documentation occur either too early or too late or not tied to actual symptom changes. And what that means is the hope time points lose meaning. So you're just, a hamster running in the wheel trying to meet all the time points but they're meaningless because it didn't coincide with changes to the patient. So that means the trend data becomes unreliable as well. So too early, too late. And I know, and just talking to folks, some folks schedule the HEV1 on day 6. It is scheduled on day 6 so they don't miss it. That's great for compliance, but what about the patient care? Because day 6 is pretty early for an update. Maybe it's not if that patient's one of those, that's has a short length of stay. But if it's too early, you're not capturing changes in that patient's condition. And then adversely, if it's too late, you may not capture what's going on with that patient. Next slide. And then there's this visit intensity misalignment. So your patient's declining, but the visits remain flat or even decrease. And so hope signals trajectory mismatch. Your patient's getting worse, but you don't change your visit frequency at all. There's a lot of background noise. The risk here is SSVI. We'll talk about that in just a moment. Plus the medical review, because visits remain flat, patients declining. And we know we have all kinds of quality outcomes related to hospice visits and last days of life and those kinds of things. So you want to make sure that everything is aligned. Next slide. Okay, so when I was reading all this and then talking to people, it's like, well, how does hope signal a trajectory mismatch? Because essentially, you're only doing those 2 HEVs in the first 30 days. After the first 30 days, the only hope assessment that would be required is a discharge. So how is it even capturing anything that happens after 30 days? The fact is it doesn't. You have symptom follow-up visits triggered by symptoms at admit and the 2 HEVs. After that, if the patient has symptoms that require intervention, it is just from your documentation. It's not in a hope. So if no hope was required and the symptoms are found between the hope visits, those visits are not transmitted to CMS, so CMS doesn't know. And so this is one of those things, like, we're collecting hope for a reason. We collected admission. We do the HEV1 within 6 to 15 days after start of care, and then HEV2 17 to 30 and or 16 to 30. And so then what happens after that? Well, Medicare doesn't have a plan at this point as far as making it available to us, at least. But we know that CMS has plans to develop a payment system based on some of this information. And so my truly a guess, is that in the future, hope will be required at least every 30 days, even after the first 30 days, to capture the changes in the patient to develop a payment system. But for right now, it's only outcomes. And so that's just, me looking at the crystal ball. Next slide. So here's some inconsistency examples. So we admit the patient. They have a moderate symptom burden. We take care of that at admission. Then at HUV, they have minimal change. And so obviously that doesn't need an SFV because it's minimal change. Claims show increasing visit intensity though, which CMS does see via claims. So in this case, the data says stable, meaning the HOPE data says the patient's stable because it shows minimal change at the HUVs. But utilization says that patient's declining. So again, HOPE cannot capture everything. And so days like 8 in 22, the HEV didn't show a lot. But in the meantime, the patient's gotten worse and you've increased visit intensity. Let's look at the next slide. And then there's sudden jumps. So symptoms worsen between visits and only captured at the next HEV. So for example, the admission, we have mild pain, no dyspnea, no symptom follow-up visit was triggered. At the HEV1, we have the same thing. Everything's pretty stable, so no SFV triggered. When you get to the HEV2, there's severe pain, there's significant decline in that patient's condition. And you see there's no intermediate signal of progression. There's like nothing at HEV1, and then all of a sudden HEV2, everything's happening. So this signals a step change without trajectory. Now, is that a data integrity problem? No, not necessarily, because the patient can actually get worse very fast. Is there a documentation gap? Maybe, maybe not. As a QA person, that's what you should look for, because if we had the admission and HEV1 looked like the patient was pretty stable, then all of a sudden HEV2 they're not good. Well, what happened between HEV1 and HEV2? You need to look at those notes there and see if the patient was declining and what did you do about it. So that's really a trigger for QA to say, they had a big change. What happened? Look at the documentation, make sure it is actually documented. Next slide. If symptoms actually occur between HU visits, but no SFV is triggered or documented, then the symptoms didn't exist in the HOPE or weren't significant enough to trigger a follow-up. Because remember, we have to have moderate or severe symptoms, symptom impact before it triggers a follow-up visit. And so if the patient's symptoms were not that bad, they did not impact the patient in moderate or severe method, you may not have done an SFV. But the utilization increases, so care is responding to the symptoms, but the HOPE data doesn't show a trigger event. Again, this is a reason for QA to look at those notes and see what's really going on. Do you have the care documented that will pass through medical review? Next slide. So the claims data fills a gap. So I've already said HOPE data is only capturing pieces of this. And if certain things are not happening at your HEV2, for example, then the SFV is not triggered, but then maybe 3 days later, they are having symptoms. So Medicare will look at the HOPE data and they'll look at the claims data. Okay, so when you have a big symptom burden in HOPE, the claims data should expect a visit frequency increased in functional status, skilled intensity. If there's triggers, then there needs to be a response to that decline. So they're going to look at claims data to see, okay, what have you done in response to this information that you collected in HOPE? Next slide. So example, patient is stable, symptoms are undocumented, there's no increase in visits, everything is just fine on every HOPE. Then you can go beyond the 30 days, of course, and then nothing is really transmitted to CMS and there's no HOPE discharge. HOPE sees stable patient, stable patient, stable patient, no obvious mismatch as far as there's no increase in visits. And so do we have a potential under documentation risk, or do we have a stable patient, which may be good, maybe not good as far as medical review? Next slide. So when you have that, you have a mismatch sometimes. So if your care team experiences the decline, but your hope data doesn't show how you got there, CMS assumes the story is incomplete, and they may, may trigger medical review. So reviewers look for continuity of decline, and hope becomes an official story if you don't have the experiences of the patient and what you've done about that in your notes. SSVI, variation between documented severity versus service intensity. And then you have your hospice visits and last days of life, then length of stay scrutiny. So long stays require credible decline trajectory, and gaps weaken that credibility. And so when you have those things going on, they look at everything to see what's going on with that patient and what's going on with your care. Next slide. Okay, so SSVI. Have y'all read about SSVI? So that is services. It's called Service and Spending Variation Index, and it's something that CMS put in the proposed rule for hospice. All hospices start out with a score of 0, and there's utilization points, and then there's non-hospice spending points. But when you have a point, it sounds like it's great, you get a point, except a point is not good. The higher number of points means you're more at risk from CMS and looking at you more closely. So the SSVI score evaluates provider performance and flags potential fraud, waste, abuse, or non-compliance concerns. Now, utilization score measures metrics like high live discharge rates, low weekend skilled visits, short average care visits per day, high proportions of patients in nursing homes, all add to your utilization score. Now, I'm just really talking about this because it relates more to hope, but the non-hospice spending score measures outside Medicare spending, such as Part A, Part B, and Part D costs incurred while the beneficiary is under a hospice selection. So what it does is hospices with higher SSVI scores, and the max is 16 points, will face increased compliance scrutiny, additional medical reviews, or targeted audits by CMS. So use your hope and your claims data and figure out where you are. Now, all this data is available to you on CMS's website. So you can see what your SSVI score is, and see where you're getting the points if you have points. And pretty much everybody has points, but remember, the lower number of points is the best. Next slide. So let's talk transmitting. Now, next slide. I got this information from Simple, which is part of my company that I work for, but they have submitted over 1 million HOPE assessments at this point. So this is the data that I received from them. So first, I want to make sure that you understand error versus warning. Error is critical errors cause rejections. They must be fixed before CMS will accept, and they have to be corrected in the electronic health record and resubmit after corrections are made. Warnings do not cause rejections. They do flag something to review, but don't necessarily require corrective action. So just remember the difference between an error and a warning. Our error is worse than a warning. It's opposite from tornadoes. I always have to think that. Error versus warning. Warning is a bad thing for tornadoes because it's right there on the ground somewhere, but warning is not a bad thing for Oasis and Hope. Okay, so let's look at the most common rejections. Next slide. Okay, so what the data showed is 64% of all rejections are due to submitting duplicate assessments. So you submitted something, it was rejected, and you modified it or something, you did something to it and sent it again. You have sent a modified HOPE when the first one wasn't accepted to begin with. That's a common thing. And then another thing is you've sent them in a batch and they've accepted the batch, and then that assessment is sent again, And so it's telling you, hey, you already submitted that one. It's a duplicate assessment. So that works in two different ways. One is you've already had that one accepted and you're trying to send it again, or it was rejected, you modified it, and then you send it again. You don't modify it if it's been rejected, because it's not in the system to begin with. If it's rejected. So this is a user process or technical workflow issue rather than clinicians repeatedly keying in the same assessment. Next slide. So these are the possible causes of duplicate assessments. So again, your AHR middleware auto retries, failed uploads, or user requeues a file that is actually accepted. And so then it will tell you, I've already got this one, quit sending it, okay? And then the batch file contains the same record twice. Next slide. Submission date issues. 22% of all rejections are due to date issues, specifically the 3032B errors. It's difficult to identify this error manually before submission to avoid rejection, as CMS uses the submission date as the point of reference. And so this one's difficult. Next slide. 9% of all rejections were due to assessments being submitted for records that did not match a previously submitted record. So then this is what I was talking about. This is often due to submission of an inactivation or modification record when the original record was never sent to or never accepted by CMS. And this is just prevented by tracking your submission status through your EHR and ensuring that you reopen edit assessments that have not been submitted. And so again, you submit an assessment, it's rejected, you have critical errors, you get it back, you do a modification and send it, and it's like, no, I don't have the one before. So don't do a modification when your assessment's been rejected to begin with. Next slide. So this is a deal right here. Hope records that have not yet been accepted by CMS include records that have been submitted and rejected, or records that have not been submitted at all. If they've been submitted and rejected, they can usually be corrected and resubmitted without any special correction procedures because they were never accepted by the system to begin with. So remember, the hospice is responsible for correcting any errors to the record prior to submission or resubmission. Next slide. Okay, so the most common issues besides those rejections from duplications. Next slide. Okay, 7% are inconsistent opioid items. So the opioid item, it's not really new because it was in his as well, but you have the bowel regimen and you have the opioid. You don't do the bowel regimen unless they have opioids. And some people try to answer all the bowel regimen issues when the patient doesn't have an opioid to begin with. So that's one. Invalid date format. This really happens when your EHR allows you to text fill those dates. And so then it has an invalid date format. Invalid value. I thought this one was interesting where people can enter in like a 9 when 9 is not even an option. And that again is an EHR issue. Inconsistent payer information, that one should be gone. That's where there was a problem with CMS. And so if you marked the payer as Medicare traditional, and you also marked Medicare managed care, maybe Medicaid, it sent an error. And you had to take everything out except for Medicare traditional, which was not true, but that's how you had to get it in. So that was about 12% of the errors there. And that one really should be gone. And then inconsistent SFV items, 18%. So let's look at some of these. Next slide. So the inconsistent SFV items is, this one consists of a group of possible issues. The most common within this group is having a blank in one of the dates. So here's an example. You marked yes, was in-person SFV completed, but J2052B, the date of in-person SFV, is blank. And so that causes an error, obviously. But that was the most common error with inconsistent SFV items. Thought that was interesting. Next slide. So just to remind you what J2051 looks like, over the past 2 days, how has the patient been affected by each of the following symptoms? Base this on your clinical assessment, including input from patient and or caregiver. Symptoms may impact multiple patient activities, including but not limited to sleep, concentration, day-to-day activities, or ability to interact with others. The mismatch that we see here is the 0 for not at all. The patient may have the symptom, but it's not affecting the patient, including symptoms that are well controlled, and then 9 not applicable, where they didn't have the symptom at all. So there were places where they put a 9 when it wasn't really a 9, it should have been a 0. So that kind of error happens, and that's not really kind of a transmission type of error, but an error in the clinicians answering the question. But here's the symptom impact, and so you see all the symptoms, and you have the rating of 0 for they have the symptom, but it's not impacting them, it's well controlled, 1 for slight, 2 for moderate, 3 for severe, or 9 they don't have that symptom at all. Remember, a 2 or 3 triggers another visit for follow-up. Next slide. So we've had late SFVs. So this is just a warning. It doesn't stop you from transmitting. So essentially, you have to do that symptom follow-up visit within 2 days of finding the symptom. And so you see the warning here. If you marked a 2 or 3, which is moderate or severe, on any of those symptoms, then the date of the in-person SFV minus the date of the symptom impact screening should be less than or equal to 2 calendar days. So if for some reason you didn't get it done within 2 calendar days, it's still good to do it. It's still best practice to get it done. But if it's late, it still gets transmitted. You don't get credit for the outcome, but you did do good by the patient. So this is just a warning. It doesn't stop you from transmitting. Next slide. And then this one is early HUVs. So you have a hospice update visit, and again, it should be the HUV1 should be between 6 and 15 days after start of care, and then the HUV2 should be 16 to 30. So remember, the AH50 is the reason for the record, either HUV1 or HUV2. A220 is admission date, and then plus how many days should be equal to the date assessment completed. So again, it's just a warning. There were lots of worried folks then when they did it early, did it late. So for example, you have it scheduled for day 30 and then the patient is not available for some reason, and you do it on day 31, or you have a mess up in the scheduling, then it's late. So again, you're late, just like if you're late with Oasis. For those of you that know Oasis well, you're late, but it's just a warning. Next slide. Okay, so how can your team improve acceptance rate and hope accuracy? So pay special attention to any flags or errors you see in the scrubber. Making the necessary corrections is the first step to improving the acceptance rate. But check every final validation report. Make sure that you're looking at the full detailed version to make sure things have been accepted. If they're not accepted, then why not? Look at the flags and correct those things, but also correct your processes so they don't happen over and over. And then if you have a scrubber, integrate review of those scrubber reports as part of the finishing touches on that assessment. And you can get such a thing as scrubber fatigue. The scrubber reports tell you to check everything and it's all just a mess. You're going to spend 45 minutes trying to check that assessment. So look at your scrubber and compare it, and you want to be efficient and correct your errors, but not spend a lot of time with the scrubber. Next slide. Okay, so why is hope submission important? Well, you have to have a 90% threshold, meaning 90% of your hope assessments have to be not only submitted, but accepted. Okay. Non-compliance means if you fall below that 90% threshold, it means 4% loss of revenue. That's a lot of revenue. So it means 4% loss of revenue. Medicare reported that 23% non-compliance rate. It's a greater than 20%, but it's 23% non-compliance rate. In other words, there's 23% of hospices that have fallen below that 90%, and some of them are way below, like they're not submitting anything. And so I always say, well, if you're one of those hospices that are getting paid for doing nothing because you really don't have any real patients, you don't really care whether you got 4% reduction, right? But most of us do care about a 4% reduction. That's a lot of money. So the other thing is that if you do fall below the 90% submission compliance, and sometimes you do just because you didn't get the I-keys, or the I-keys person who's in charge left, and you don't have. There's all kinds of reasons why you may fall below the 90% HOPE submission compliance rate, other than just outright fraud and abuse. But just remember that you want to get it corrected. If it's not above the 90% threshold, you need to get it corrected. And the other thing is CMS has proposed an icon to be placed on Care Compare, such as you see in the little picture over here, where Hospice C has 1 star, and they have an icon that indicates that they're not actually submitting data. Okay, so that will publicly identify your hospice on Care Compare if you're not meeting that 90% threshold. Next slide. Okay, now this is found in the proposed rule. This is good news for those that either you didn't get ready in time, or you did get ready in time but had all kinds of problems. So they said, due to the newness of the HOPE assessment along with the migration to the iKeys platform, CMS has granted a waiver to all HOPE assessments dated October 1st through December 31st. And as a result, all HOPE assessments with a target date in 2025 will be considered timely. So even if you messed up and you didn't get it submitted in time in 2025, you were given grace. And so, but as of January 1st, 2026, you're expected to be transmitting those HOPE assessments on time. And remember, they had to be transmitted and accepted on time. So 30 days from that target date. Next slide. Now, length of stay extremes create opposite HOPE risks. So I just thought I'd add this in because I thought it was interesting. So there are lots of folks that they have these patients that are really, really sick right when they admit them. And then they have these patients that have long lengths of stay. So those that operate on the tail ends of the extremes, those always raise red flags with CMS. So everybody has one, some of these patients, but where the extremes matter is when you have all your patients at one end other than the other end. Okay, so you have a short length of stay concentration, which is less than or equal to 7 or less than or equal to 14 days. HOPE data becomes incomplete, it becomes rushed, and it's symptom heavy without intervention trend. You are trying to react to the patient's symptoms, and you may not have done an SFV, or maybe they died before the SFV. All kinds of things happen. You have minimal opportunity to demonstrate symptom improvement, goal alignment, care planning progression, and that's really what you want to show in your outcomes to Medicare. Is that I've regarded this patient's condition and I have intervened appropriately. So HOPE may technically be completed, but it lacks clinical narrative credibility because everything happens so fast. Next slide. And then we have the opposite, long length of stay concentration greater than 180 days. HOPE exposes repetition, symptom scoring without change, flat functional trajectories, weak evidence of terminal decline over time, and no HOPE transitions over a length of time with continuing claims. Now, this one I thought was, well, you're not going to be transmitting HOPE anyway, except for the discharge. So after 30 days, there's not a hope required. And so here is the patient out here. There's no hope being collected or submitted. And the patient has, one visit every once in a while. There's weak evidence of terminal decline over time. And then you don't have another hope for a long period of time when the patient's finally discharged, either a live discharge or, a discharge with death. But this kind of pattern invites prognosis skepticism. So keep that in mind. Next slide. Those are my resources, and I'll give it back to you, Dan.
Great. Thanks so much, Lisa. So much good information there. Can you just let me know if you can hear me okay?
I can hear you fine.
Okay, perfect. I had some technical wackiness, so just want to make sure everyone wasn't sitting there in silence. Thanks, Lisa. All right. Now it is time to bring you through our scenario spotlight. And we had a scenario in May where a start of care clinician was completing the medication reconciliation. This is in home health using the hospital discharge summary and confirmed prescription bottles in the home. During the survey, the patient reports taking several supplements and PRN over the counter medications not listed in the chart. And we asked you which statement is the most accurate. And our correct answer for the May scenario is item number B. All items the patient takes should be reviewed and documented. And for June, we have a new scenario for you. A patient was admitted to hospice, and the RN performed a symptom impact assessment at the admission on June 1st, 2026. The scores for the items were all 0 and 1 for none to mild symptom impact upon admission. The HUV1 visit was done on 6/10/26, and at this visit, the symptom impact scores for the items were all 0 to 1, none to mild, except that pain was scored as moderate symptom impact. The nurse documents teaching and a change of medication for pain management was ordered during the visit on 6/10/26, but the patient refused to begin taking the medication because he felt the pain, though impactful, was tolerable and didn't want to just sleep all the time. In regards to the symptom follow-up visits for this scenario, which statement is most accurate? And we have four choices for you there. A, an SFV was required after the start of care and should have been done on or before 6/26. B, an SFV is required to be done on or before 48 hours from the 6/10/26 HUV1 visit. C, an SFV is needed but can be done at the HUV2 visit on days 16 to 30. Or D, the SFV is not required at all for this scenario. And we give you that scenario to think about, and we will let you know the correct answer and the rationale when we get together in July. And now it's time for our product spotlight. And this month's episode of Oc Talk is brought to you by Ox Coding and Oasis Credentials. Credential your coding and Oasis team, strengthen your agency's bottom line. Strong coders equal stronger compliance. Encourage your team to earn OC credentials and elevate your agency's reputation, audit readiness, and financial outcomes. Learn how credentialing pays at the link in your handouts or by visiting the certification section of the Decision Health website. If you are listening to a podcast version of this call, you'll find the handouts, including the link on the OC website under Resources, Free Webinars. And now it's time for What's New with OC, where we share updates from the Association of Home Care Coding and Compliance. If you are an OC member, we have an OC members educational call coming up on June 24th, when we'll be talking about diagnosis coding and the Hospice Hope tool. Watch your email for a link to register. On this call, we'll be going over some hospice coding basics and discussing how the Hope tool and coding intersect. And we hope you will join us for that call. This will be brought to you by members of the OC Education Committee. And in addition, OCK members, watch your email for another invitation to join us in August for a virtual pool party where we will be putting our coding and OASIS skills to the test with some fun and games and quizzes. We hope you enjoyed this episode of OCK Talk. Thanks again, Lisa, for all the great information, and thanks to all of you for tuning in. We hope you'll join us again for our July call on the 13th when Christine Mickle will join us to talk about the impact coding and OASIS data play on accurate reimbursement. And that idea for an episode came from a longtime OCK Talk listener. So if you have any suggestions for future guest topics or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. We're always looking forward to your ideas and excited to bring you programs that address your questions. And in the meantime, between now and our next episode, if you'd like to re-listen to this episode or a previous one on the go, you can find OCK Talk on your favorite podcast app, or you can also listen to the recording and access the handouts on the OCK website at ock.decisionhealth.com. Thanks so much for listening. Thanks again, Lisa, for the great presentation, and we will see you all next month. Take care.
Thank you. Have a good day.
Thanks. You too. Bye-bye.